All right, welcome to our second case today. Welcome to Harbin. So before we start it, let me first introduce the first operator, Dr. Qingfeng Sun.
Hi.
Second operator, Wang Haijun. My name is Zhou Qingyun. I'll be the moderator today. Next slide. So I'll briefly introduce the history of this patient. This gentleman is 54 years old with hypertension, type 2 diabetic mellitus, and hyperlipidemia. He presented to us with left limb intermediate claudication, which is rated Rutherford third. He is a smoker, and before he committed to the hospital, he was taking clopidogrel. After he was being hospitalized, he was taking statin. So for the physical examination, the skin temperature is quite normal compared with the right side, and there is no muscle atrophy. But we cannot reach the pulse of distal arteries. So for the ABI, the left pope is 0.761, anterior AT is 0.58, PT is 0.57. And for the ultrasound, it reported that left SFA is severe stenosis, and the bloodstream velocity is significantly increased. Next, please. This is his CTA before the operation. We can see that basically the most of the lower limb arteries are pretty good, but if you zoom in, we can see at the distal SFA there's a severe stenosis, which is almost occluded, and for the arteries below the knee, which is also very thin, but it's not very surprising compared with consider about the medical history of type 2 diabetes. Next, please. So this is a cross section. We can see there's quite a lot of calcification around the lesion, and there's some low density of the disease on the vessel wall. So is it thrombosis or soft plaque or just a fibrinosis? We will interpret it later in the by using IVUS. So for today's procedure, first we'll use 6 or 7 French long sheaths for the vessel access and crossover. And we have a bunch of glide wires and wires for V18 command 14, glide wires for the passage. And the most important thing for today's case is IVUS, which is quite important for us to determine the character of the disease, right? And for the vessel preparation, it depends on the IVUS results. If it's mainly composed by thrombosis, we're using debulking methods, using roller racks or strop. And if it's just mainly fibrinosis or soft plaque, we'll use just the PTA, progressive PTA. And for the final, we prepared a DCB, but just in case, we also have Viban and the Illuvia, which is DES, just for different conditions. Okay. Can we show the angio? Angio first.
Angiography.
Can we operate from here?
No.
Okay. No worries. Take your time. Start from the first one.
First,
No worry.
okay.
No worry. The first one, please.
No.
The very first one.
Yes.
Okay. So this is the first picture we've taken after we cross over. We can see the CFA, the SFA, and the DFA, which is fairly good, especially for the SFA in the proximal segment. But there's a severe stenosis at the distal SFA, which you can see there is almost occluded. Next, please.
Next.
Next. Okay, this is a little bit of distal. So we can see the disease more clearly here. And there's a lot of collateral generated. And we can see the pulp. There's some disease lesion on the pulp. And next, please.
Next.
No. Just going back a little. Going back one. We want to see the pulp.
No. Next. Next.
Shine.
This one, please.
No.
You're going too far. You're going too far. Go back. Go back. Go back. Go back. Go back.
Yeah,
Number
yes.
5. Let us see number 5.
Yes.
It's just a picture. It's not angio. Okay. All right. There we go. So the arteries below the knee, we can only see the proneal and the PT. Yeah. Okay. The AT is completely occluded. Next one, please. And for the foot, we can see the PT, of course, crossing ankle, and the proneal connected to the PT through collaterals. I'll say it's a glass P1.
Yeah.
Right? Okay. And next one, please. So, okay, we can see, this is just a picture. We can see the severe calcification on the SFA, which is around the lesion. Next one, please. Next one, please.
Next one.
Number 8. Number 8. Number 8.
Yes.
All right. Next one.
Next one.
Next.
Next.
Okay, this is a roadmap before we cross it, and it's quite clear. So this is a severe stenosis with a lot of collateral generated. So is it do you more inclined to the chronic disease like fibrinosis or soft plaque, or you think it's more like a thrombosis? It's hard to say, right? It's hard to say. That's why we're having IVLs here.
Yeah.
So next one, please. Play it. Play it.
Play. No.
Number 10. We need number 10.
Yes.
Play. Yeah. There we go. So we are using 14 crossing the lesion, which is I will say quite easily just some angle and just cross it. Okay. And probably because just it's a stenosis but not occluded, and I think we're good, right? So next, after we pass the lesion, we're using IVUS by the guidance of Dr. Dongyong Tai. Thanks you very much. And could you play the IVUS image? All right, there we go.
Okay. After the Y cross the lesion, we perform the initial IVUS imaging. As we know, this is a very important intravascular image for guiding the precise procedure.
Exactly.
Okay, we can review the imaging.
Mm-hmm. So this is a lumen. Lumen is quite big.
Yes.
So I would say this gentleman's SF is quite big. Not like most of the Asian, more like a Caucasian, right?
Yeah.
7 millimeter around. And so are we? We're getting close to the lesion.
Yeah.
Going. Oh, there you go. There you go. So we can see that, and suddenly the lumen is coming back again.
Yeah.
And there's a quite a lot of calcification, right, Dr. Gong?
Yes. The length of the lesion is about 14 millimeter.
40 millimeter.
40.
Yeah.
So what do you think of the character of the lesion? Is it more like a fibrinosis or thrombosis? What do you think?
Fibrotic.
Okay.
Of course, in the severe stenosis lesion,
Mm-hmm.
they are
Lipid plaque?
lipid rich.
Okay. Some lipid plaque composed with fibrinosis. So are we good for the progressive PTA? Dr. Song?
Yeah.
Okay. Okay. So
After measurement, the distal segment of the landing zone, the lumen area is about 22, and the mean lumen diameter is about 4.5.
4.5. Oh,
yeah.
okay.
And in the most minimal lumen area is about only about 4.56 millimeter square.
Mm-hmm. So what about the proximal diameter for the landing zone?
For the proximal landing zone, the vessel is very big,
Mm-hmm.
and
Of course, yeah.
in the plaque burden less than 14 percent, just need more than 14 length span.
40.
Yeah.
Okay. So the length is 40, the distal is 4.5, and proximal is around like 7 millimeter, right?
Yeah.
Okay.
Okay, so it's quite differences, right?
Yeah.
All right, thank you very much, Dr. Gong. So shall we proceed?
Yes.
Okay.
From the under graph under the iris, we think this is a stenosis, and with the femoral
Fibrinosis?
fibrinosis.
Yes, yes.
So we use the gradual gluten PTA from the 3,
Okay.
3, 4, 5.
Okay.
Okay. So
Start from the 3, all right?
okay.
So there's okay. Can we get a 3? Through what?
Sterling.
Sterling. Can we have a sterling bloom for 3 or for how long?
100 呢?
3100.
3100.
Okay. 3100 sterling bloom, please. Anyone?
No 3. 4.
We have 4? Okay, no 3? So we have 4? 4 100? Uh-huh. 4 120. 4 120.
Okay.
All right, 4 120. Okay. Yeah. So 4 100. All right. That's what we want. All right, there we go. Okay, pump.
Roadmap. Yes.
All right. So we have 4 100.
Okay.
4 100. This is Saber.
Okay.
from Cordis.
Okay.
And
we use the two guide wire.
Two guide wires. So, Dr. Sun, you are planning using two guide wires when you're doing PTA. So it's more like a cutting balloon stuff?
Yeah.
Okay.
It's also like just like a scouting balloon.
Okay, okay. All right. During this time, I actually want to bring some information about the why we doing this case and how we do it. So for our center, this kind of type task, I would say is task A or B. Task A or B. Task A lesion patients is quite rare. So most of the patients committed to our hospital and the center are mostly type C or D. So why are we taking this case to the to the live stream? That is because we can still learn a lot of stuff from this quite, I would say, fairly simple case. And so the strategy of deciding what's the character of the lesion, and the strategy of the vessel preparation, and the strategy of the final solution. So we can see the stenosis here by the blooming. It's quite significant, huh?
Dr. Sun, can you hear me?
Yeah.
We got a question from the audience.
Okay.
Someone asked if this is a suitable case for IVL.
Pardon me, please?
If this case is suitable for IVL, intravascular lithotripsy.
No.
Oh.
I don't think so.
There we go.
The IVL will use for the calcification, and we use the iris. It is the calcification is outside, and the inner is the fibrosis.
Yeah.
So we don't use the IVL.
Yeah, so that's also answers the importance of the IVUS. So there's another question I want to bring to Dr. Sun. So for a lot of base hospital, not in our center, so they have most of the patients are graded like task A or B, which is quite simple. Some cases like this, so they don't have IVUS. All right. So how do they decide what's the character of the disease? What's your opinion?
It's difficult to see, but it's a good question. I think maybe we use the medical history, and we the most is the Doppler.
Oh, okay.
Doppler
IVUS.
IVUS. No, IVUS. Doppler.
Oh, okay.
The Doppler.
Okay, before the surgery. Okay.
We can see the plaque. The plaque is the high or low echo.
Okay.
We can just
okay. So ultrasound is quite important for this kind of this kind of hospital. You know, I would say not every hospital in China has IVUS.
Yeah.
So it's fairly say it's a quite expensive equipment. So for the most base hospital, they don't have the equipment, and they also want to decide what's the character of this disease. So this is very valuable for most of people. So I think that's why we are using this case as the live stream case to the purpose of education, right?
Yeah. At first, I think that I see the CT angiograph under the cross section. I thought it is thrombosis.
Yeah, definitely.
But use the iris, we can see it is the fibrosis.
Yeah, so it's quite different.
Yeah.
So yes, indeed. On the slide we show, Dr. Gong, can we show me the slide, last one, the cross section for the CTA. Yeah. So can we see the PPT right now? All right, doesn't matter. So just as Dr. Sun said, when we see in the CTA, which is most which is the most common message for most of doctors in China to decide what's the character of the disease. You can see some low density stuff on the vessel wall. So based on this and also his medical history, this gentleman is just having claudication for 1 month. So it's fairly easy for us to think the lesion is composed of thrombosis. But when you're using IVUS, actually you can see a completely different results. So you want a 5 balloon, 5 millimeter?
5 balloon.
Okay, can we have a 5 millimeter balloon? Can we have a 5 millimeter balloon? And we know that there's also a novel bloom called chocolate bloom, which is on Medtronic, right? Is it from Medtronic?
No.
No. Okay.
Safer. No ceiling. Yeah. This one.
Sterling. Okay, we are having Sterling 5 100s bloom. So there's a novel bloom, which is chocolate bloom for reducing the dissection, which is the same mechanism as we're doing here. Gradal dilation.
Yeah, gradal dilation.
Okay, so still there's I would say there's not every hospital and not every doctor has chocolate bloom. Of course, it's good stuff. Of course, it's a good product, but it's not very not easy for everyone.
Yeah.
So when we are doing such kind of surgery in the base hospital, we can also doing the old school way, which is gradal dilation, using a different diameter balloon from small to the larger ones, so to reduce the dissections. Yes, and if the pre-dilation vessel preparation is pretty good, we can reduce the stent grafting, right?
Yeah.
So we can just use a DCB or some debulking methods just to avoid doing stenting, which is quite good for the patients. Patient is quite young, relatively, 54 years old. So he, if we are doing stenting this early, probably he will come back to hospital again. So yeah, this is I think this is the main purpose for we choosing this fairly simple, fairly easy case for the broadcast today. And here we go. We have the 5 millimeter Sterling bloom to the lesion, and we have going again. Nominal is 6. Nominal is 6. Here we go.
Okay.
Oh, there is still some stenosis. We can see that from the expanding.
Yeah.
Here we go.
Okay.
For like 3 minutes. 6. Nominal is 6. Nominal is 6. Yeah. There we go.
We finally use the 6 millimeters.
6 millimeter for the final.
So it's 2 minutes.
Okay, 2 minutes. All right, 2 minutes. So we have using we are planning using 3 diameters. First is 4, 5, and 6 for the gradal dilation, and we'll see the final angio. And we of course we will use IVUS again, right?
Yeah.
We'll use IVUS again to see if there's some different kind of dissection. If it's going well, we'll just do DCB. All right?
Yeah.
Is that okay?
There's no flow limited dissection. We can use the DCB. No. The 6. The pulp, saber or sterling.
6.
Dr. Sun, we have a few more questions from the audience.
Yeah, please go ahead.
Do you want to ask, except the approach you are using, what do you think of the use of rotational atherectomy?
Oh, there we go.
What do you think of the use of rotational atherectomy for this case?
I will ask you this. They're basically choosing balloon. So I will ask you this question.
Okay.
Actually, we have a very thorough preparation for this using rotor racks or strop some other stuff to debulking. So based on the IVLs, so it's not quite suitable for the rotor racks. If it's mainly composed by thrombosis, definitely you are using debulking methods. But for this kind of, it's more like a calcification, and you have fibrinosis. So debulking might not that good enough.
Good,
yeah.
yes.
So you are using it, you are wasting money, and you cannot get what you want. So in this case, we prefer the old school way, right? The old school way. That would be much better.
Okay. And we have another question. This is except for the use of AVAS, any other tools you want to use for this case?
Pardon me, please?
Except for the use of AVAS, is there any other tools you want to use for this case?
Okay. I think if we have a perfect vessel preparation, the next one is DCB, right?
Yeah, yeah, yeah.
DCB.
And leave nothing behind.
Yeah, of course, leave nothing behind, which is quite popular right now, right?
Okay. So we do the intervention, but we leave nothing behind.
No, of course, definitely. More precisely, we won't leave right thing behind, not nothing behind.
You're right.
So this is 6 bloom, right?
It's 5 balloon.
Oh, 5 bloom. Oh, okay. Next one is 6.
Yeah, we will be the undergraphy and use
Okay.
the.
Here we go.
You can see.
Uh-huh.
Very okay.
Looks good, right?
Yeah.
Hopefully it's still good for the last one. Okay, so for the 6mm balloon, it's going for both wire, right?
Yeah,
Inside.
Yeah.
Both wire on track.
Because it's the 3-5 system. The balloon.
Okay. So you don't want the cutting effect for the 6.
No.
Because the 6 is quite large enough, right?
Yeah.
If you are still cutting, it's more like generally dissection or perforation, hemorrhage, a lot of things we don't want to see.
Okay.
So people, you can see that. Let me emphasize again. This is a quite simple, quite easy case, but we can still now learn a lot of things from this simple case. So people, please notice that, and how we choose the different size of balloon, and how we adjust using different wires, and how we using wires to cross the lesion. So it's quite interesting, you know. For 4 and 5mm diameter, we're using cutting effect, and for 6, which is quite almost the same diameter as the vessel, we are losing it. We're just not quitting using the cutting effect. It's quite interesting. So thank you, Dr. This is pretty good. I learned a lot for myself. Definitely. So this one also go 2 minutes? 3 minutes. Oh, okay, 3 minutes. After that, we're using IVUS again, right?
For the debugging, maybe like a duck or PMT.
Okay.
Oh, okay. It's good for the vessel preparation, but in China, it's maybe the expensive.
I know. Yeah, I feel you. So yeah, definitely. People from the world probably this platform is broadcasting around the world. So and people from different countries have different conditions for themselves. So we also see some colleagues from US or some Western world using a lot of great instruments for treating patients. But to be honest, in China, we have to be accountant for the patients first, right? We have to calculating and for the expense for the patient. So if the patient's economic condition is acceptable, we probably will choose PMT or DART. But most of the people, we will choose a fairly cheap way to do the big thing, right?
So we use the two gear wire, two gear wire for, and one is inside and blue, and one is outside blue. We use the cutting balloon or scalding balloon to expensive.
Yes, cutting balloon. Yeah. Still, not every doctor has cutting balloon, right?
Yeah.
So we have to use some ways that we make by ourselves to make the effect, which is fairly good. Yeah, I like it.
Okay.
There we go.
It means. So we undergrad first and use the iris
to do it again. Okay, iris again.
Oh no.
Let's see if there's some restricted dissection. If not, we're going for using DCB for the good. So what if we have a restricted dissection for this lesion? Are we going for the standing?
Yeah, if we have the flow limited dissection, we use the jogging blue stand.
Hey, Dr. Sun, I'm so sorry to interrupt you again. Even though you are not going to use IVL for this patient, but the audience is very interested in the use of peripheral IVL. They want to ask you if you have any experience about the use of peripheral IVL, like how many pulses a peripheral IVL may deploy.
Sorry, pardon me, please. So using IVL or something?
Yeah. If you use a peripheral IVL, how many pulses a peripheral IVL may deploy?
Well, how many pulses? Okay. So back on our old questions and old answers. Not every doctor has such advanced instrument. So I can be honest for the audience online. For our center, we just using IVL just for once. So if you are asking, do we have a lot of experience for using that? I will honestly answer you that no.
Okay.
So we don't have such experience for using IVL, but we do have a lot of old school ways to dealing with such lesions, which is also good for our patients. So they improve their quality of life. They are happy, and we don't expend that much money. Yeah. So like I just said in the beginning, there's doctors broadcasting their treatments, their practice around the world on this platform, and different countries have different conditions. So you might want to know some advanced technology, but we also know the advanced technology, which is good for the patients. But for the actual condition, there's fairly we use it very less.
Okay, we got it. Maybe we have many approaches for the same case. Here we got another question. Like they ask, what are the risks of recalcification and restenosis after this procedure?
After the procedure, okay. Yeah. So I think it depends on what we do next. If we will do if there's a no dissection, we're using DCB. There's a dissection, we're probably using a standing. So I would say in old times we will implant a little bit longer standing, like 100 millimeter. But right now, I know in the Western company and some Chinese company also experiencing some short segment of the stand, just for rescuing the dissection, which is pretty good. But we are still on the clinical trial. our center is one of the
okay.
one of the centers for the clinical trial. So if it's shorter, stenting definitely will be better than longer.
Okay, we use the iris to check after balloon.
All right. So we'll need Dr. Gong's help for interpreting the IVUS again.
Okay. After Foley predilation, you can see the lesion. Okay. This is the distal segment of the lesion.
Dr. Sun, they want to know the risk stenosis rate of DCB or stenting for this segment.
30%.
Okay.
30%. Okay.
You can see the.
So this is the direct answer for that 30%. Yeah.
Yeah. The plaque has been fully modified by the predilation, and we can in some segment there are dissection.
Oh, some dissection. Is
Yeah.
it? Okay. Which is not surprising, right? For some short segment of dissection.
Okay.
And
this is the proximal segment. It's very health segment, but in the middle segment, in the plaque and the severe stenosis, we can see the dissection. Dissection, as we know.
So can we using IVUS to determine the types of the dissections, or we more depend on the angio?
Angio.
Okay. There you go. Angio. So is it because the most the current classification of dissection is based on the angio? Or you think angio is more like your way?
We'll go the metal angio.
Okay, so doing different angles, and we can see the doing angio. We'll see if it's a restricted dissection, right?
Yeah.
So now we are turning quite a bit angle, LAO, 35 degrees, and we're doing angio again to see if there's a restricted dissection. Is it good?
I think it's no.
I think it's good, right?
Yeah.
It's good for me. Some places more like the interference of the guide wire.
Okay, the dissection limited to the intimal.
Intimal. Okay.
Yes, that means it just plaque crack. Not into the media. And we know if the dissection into the India, this into the media, which may have the risk of the extension to the distal segment.
There we go. Yeah.
Which one is the B?
Yeah.
Oh yeah, it's more like a type B dissection. So for the classification of dissections and is a type B dissection good for you, Dr. Sun?
Type B, or I think with type B dissection.
Yeah. So is it good for you? You think it's necessary for stenting?
I think maybe the balloon DCB is okay.
DCB is all right.
Yeah.
So for
we also can use the to test the blood, the blood pressure, the
distal and the proximal.
Yes.
So we can see the differences from the pressure, right?
Yeah.
To see if it's restricted.
So
what's the next? Do you think DCB is all right for this one? So we think type A and B is benign. And C2F is
blood flow. We use the neck.
So in this case, we are going to use DCB, which is after special preparation, we can see a type B dissection. From literature, we think that type A and B is quite benign dissection, but if it's C to F, would be pretty bad. I think we definitely need some interventions for those dissections. But for now, we're good. Okay, get the IVS. There we go. So after using DCB, we'll do. After DCB, we're using IVS again.
Close. 那个要
So move forward. What do you want? Okay. Pressure. Okay. So we want to test the pressure to see the dissection is necessary for the intervention.
Judge Zhou, we have 3 more questions.
Oh.
So the audience wants to know what is the longest stance in our cath lab?
In our center, in our hospital, the longest one, I think is 150.
150.
I think the 150.
From which company?
EV3.
All right.
Might be the longest. They want to know the longest stand in our hospital. 150 EV3, right? I think so. Is there 200 stand?
No.
Yeah, just the 150.
Right?
Yeah, 150.
Okay. And the second question is, just if you fail in the interventional management of this lesion, will you consider surgery?
Definitely.
Okay.
Definitely. So for our department, it's definitely 2 hands for preparation. 1 hand is for the intervention. The other hand is for open surgery. So if you don't have the skill of open surgery, you're not qualified.
Okay.
Definitely.
So we always have a backup plan.
Definitely. Yeah.
So the last question is, in general, what is your wear escalation strategy?
Wear escalation.
Yeah.
I'm not quite get it. Could you come again?
You know, the wear escalation. Maybe you try one wear first. If it doesn't work, you try another wear.
So the wires are choosing, right?
Yeah.
I would say for this kind of lesion, because it's quite severely stenosis, so we will use definitely the thinnest wire to cross. So that's why Dr. Sun chose the 0.014 first. And it's also quite good. It's good for suitable for the IVS. So after we pass it using 0.14, and we can just going into the IVS and examine the lesion, which is quite convenient. But if it's completely occluded, we might try a CTO wire first.
A much harder wire, right?
Yeah, probably, yeah. And also, if you're a CTO lesion, you definitely need some strong enough support for the CTO wire to get through.
So can you give us some specific names for those kind of wires?
I think command 14 is quite good for CTO, and for our center, most of the doctors using V18. You can actually shape the tip, and so you can cooperate with the catheter, which is fairly good. I would say fairly good.
All right.
So we are preparing for the pressure measurement. Dr. Sun wanted to decide if there's any differences between distal and proximal blood pressure. So if there's so how do you decide? I mean, how much the differences you think is qualified for intervention?
20
20 millimeter. Okay, 20.
20.
So we'll see. Finger crossed. I hope we don't have to plant any stand inside.
Okay. It's 0. It's okay.
I got the wire.
Yeah. No. Okay.
I would also bring out a question for this case. So recently, I think it's just the May of the 2023. There's a paper published at the Journal of Vascular Surgery, and it says that they don't, after 4 years follow-up, they don't recommend the early intervention for the calcification patient. So it will cause higher risk of amputation, higher risk of re-intervent, and also the New England Journal of Medicine also quote this publication and have editor comments on it. So, Dr. Sun, do you
see the plus?
Okay.
The pressure.
Okay.
Blood pressure.
There we go.
How we see the how much?
Can we have a vision on the blood pressure?
133 over 75.
133.
3 over 75.
Okay. 133. So we'll move to distal part?
Yeah.
133.
No. It's not work.
Oh, there we go. This
okay. It's
100? Around 100. Okay, so the difference is 30 millimeter mercury. So what do you think, Dr. Sun?
Well, we will go out and then distal.
Okay, distal. Oh, so this is, the catheter is still in proximal. All right.
Yeah.
So this is the actual blood pressure, 100.
And there
we go.
Go to
distal.
Here?
Yeah. Here at Pope.
Oh, yeah.
Okay, P1 segment.
Yeah.
And we are having the reading, which is also the 100, right?
No different.
No difference. Yeah, no difference.
The section is the flow limited. Flow limited.
Okay.
So we use the DCB.
All right.
Okay. Open the DCB.
So DCB, how we choosing the size? So like
six,
I mentioned,
the diameter is 6
millimeter.
Yeah.
Okay. So like I mentioned in the first, this gentleman has a quite thick SFA, which is almost 7 millimeter, which is fairly rare in Asian population. So it's more like a Caucasian, and so by the choosing of the DCB of the diameter, we know that is quite important. So if it's big enough, the drugs cannot fully dispatched. So if it's too big, definitely will generate a new dissection. So we are also still using a dual wire technique.
No.
No.
It only used.
One wire. Okay.
Yeah. No. 2 wire.
2 wire.
2 wire. But is supposed to DCB.
Okay. So you are using DCB. You are also using that cutting effect.
Parking? No, no, no.
Oh, okay. I'll get you. So you have enough support, right?
Yeah.
Over the two wires. Okay.
Yeah.
So you don't have to change the wire,
Yeah,
right?
yeah, yes.
Okay. See, you learn a lot. A lot of tricks and tips. A lot of trick and tips to people. So I think that's the why we're having this platform. Broadcasting 724 around the world for tips and tricks. So we are having this DCB, which is Arcotech, right?
Yes.
Arcotech DCB, which is produced by a Chinese company, and
we use the more than 5 years. So yes,
more than 5 years
yes.
in Chinese company DCB, which is pretty good,
Yeah.
and we the patients also having a lot of advantage from this product. We love it, and we hoping they are having much better, more advanced DCB or other instrument for the patients. There we go. The DCB for the lesion. And,
yeah, it's okay.
We have the pump here.
Yeah. The pressure is 8.
What's the nominal of this one?
8.
8. Oh, there we go. There we go. So it's 6. So nominal is 6.
6.
Yeah,
okay.
Nominal is 6. That's going into 6 and for 3 minutes.
Yeah.
So during this time, I have to bring up this question to Dr. Sun. So recently, there's a publication on Journal of Vascular Surgery and saying that for stable claudification patients, they recommend for late intervention, not early intervention. If you're doing it too early, which is within the 6 months after diagnosis, it might increase the amputation rate, increase the re-stenosis rate. So what do you think about this?
Just like the carotid stenosis, maybe maybe the aspirin and the Claudia and the
statin,
statin is very okay for this person. So I think maybe in the lemma is the qualification is okay for the late intervention.
So for our case today, first I think we might considering the patient's willing, right?
Yeah.
This gentleman is fairly young, 54 years old, and he can only walk like 100 meters, which is the patients want more for the life quality. So they actually they decided for the doctors to do the intervention. Although from the literature, it might be having some side effects or increase the rate of reintervention in the future, but we definitely should consider the patient's willing in the first place, right? And also, if we consider the medical history, he is type 2 diabetes, and if we just let this go, and probably the lesion will get longer and harder for the first intervention in the future, right? So yeah.
So we use the DCB for leave nothing behind for the next, if possible, next next intervention, maybe easy to
cross the lesion.
Yeah.
So if we have a stent, that will be RSR, and RSR is definitely more difficult for cross and for the next intervention. Yeah. So if we leave nothing inside the patients, and if we need to intervene next time, it will be much better, much easier.
Yes. It's okay.
So are we checking the time?
Yeah. And then we check by the angiograph, and no errors.
What do you think, Dr. Smith? You want to do IVUS scan?
No.
No?
It is also has the dissection. Maybe the DCB also has dissection.
Okay. Okay. So it's not necessary, right?
Yeah.
So we'll decide. We'll see it from the angio, the
Angio
final
and
angio.
the
Okay.
auto angio.
Okay.
So what is the anti-thrombotic strategy after the use of DCB?
Pardon me, please.
The anti-thrombotic strategy.
Anti-thrombotic.
Yeah.
I would say the distal thrombotic rate is quite low.
I mean, what kind of drugs to use to against the platelet aggregation? Like
okay. So there we go.
Yeah.
So the anti so
you will give like double antiplatelet therapy?
No.
Only single?
No, two.
Single, yeah, might be. We also have anticoagulation, and sometimes we also use the vessel active drugs to dilation the vessels like in the toe or whatever, which is quite small. You cannot reach by the instrument, but you can use medicine to open it. So that but fairly enough, it's the distal thrombosis rate is quite low in here.
I mean, what is the routine treatment after the use of DCB? Like single antiplatelet therapy plus anticoagulant?
Anticoagulant plus